Hello everyone, welcome back to the channel. I'm glad you're here today because we're going to cover a very important topic in pediatric and adult care, diarrhea. Now, don't think this is just a minor stomach problem. Diarrhea is a major cause of illness and death, especially in children under 5 years. So, whether you are a healthcare student, a parent, or a nurse, understanding this topic is critical. So, by the end of this video, you will understand what diarrhea is, causes and risk factors, how to assess it, clinical manifestations, step-by-step management using plan A, B, and C. And also we're going to have some patient scenarios, and we'll finish with a quiz to test your knowledge. So grab a pen, take notes, and let's dive in. So what is diarrhea? Diarrhea can be defined as the passage of more than 200 grams per day of loose stool. It is also defined as passage of loose stool more than 3 times a day. Not only that, it can also be defined as 3 or more loose or watery stools in a 24-hour period. So, if a child passes watery stools 4 to 5 times in a day, that counts as diarrhea. Frequency and consistency are key. Okay, let's look at the assessment of diarrhea. So, assessment is critical, especially in children. So the first step, you need to ask the caregiver if at all the child has had diarrhea. Now, if the caregiver says no, no further diarrhea assessment is needed. But if the caregiver says yes, you need to assess for dehydration, assess for persistent diarrhea, meaning the diarrhea which lasts more than 14 days. Also assess for dysentery, meaning you're asking if at all there is any blood in stool. So you ask the caregiver how long that child has had that diarrhea, the frequency of that diarrhea, if there's any blood in the stool, if the child is vomiting, you also ask. Then you also need to ask if the child is drinking. Okay, here's a patient scenario. For example, a mother brings a 2-year-old child who has watery stools 5 times a day for 7 days. She says the child is irritable and refuses to drink much. Here we immediately need to assess the severity of dehydration. Now let's look at the causes of diarrhea before we look at the manifestations. So there's multiple causes of diarrhea. We have infections of the gut. This can be as a result of viruses, bacteria, amoeba. Okay, so they can damage the gut wall. Once this happens, it leads to poor absorptions, which result into watery stools. Then there is malnutrition as one of the causes. So malnutrition weakens the gut wall. When that happens, it means that the food cannot be digested, and hence it passes out as stool. Then we also have osmotic diarrhea as one of the causes. So this one is as a result of non-absorbable substances which draw water into the intestine, and hence leading to watery stools. Then we also have dirty environment. So dirty environment transmission is through the 5 F's: the flies, vomit, food, feces, and fingers. So it is important to note that diarrhea in infants less than 1 week is rare and often signals neonatal sepsis. Okay, now let's look at the clinical features or manifestations. So the clinical features depend on severity of dehydration. So we classify as no or mild dehydration, some dehydration, and severe dehydration. Okay, now let's start by looking at no or mild dehydration. So the signs that you're going to see in mild or no dehydration, there's going to be few or no abnormal signs. The child may drink normally, and then the urine output may be slightly reduced. Now, in this mild or no dehydration, there's going to be minimal fluid loss. This means that the body is going to compensate. Therefore, this is why we see mild or no systemic effects. Another classification is some dehydration. Now, for you to say a child or to classify a child as having some dehydration, there has to be any two of the following signs: less stress or irritable. So this is due to mild hypovolemia affecting brain perfusion. Sunken eyes, which is as a result of fluid loss, which reduces intraorbital tissue turgor. Also, the child is usually thirsty. Okay, this is as a result, or it's because the body's compensatory mechanism has to replace the lost fluid. Then there's also you notice that when you pinch the skin goes back slowly because there's reduced skin turgor due to dehydration. The last classification is severe dehydration. Okay, so for you to classify a child as having severe dehydration, the child has to have any two of the following signs: lethargic or unconscious. So this is as a result of cerebral hypoperfusion. There is also sunken eyes, which is as a result of severe fluid loss. Also, the child may not be able to drink, or maybe they drink poorly. This is due to extreme fatigue or shock. Then when you do a skin pinch, you'll notice that it goes back very slowly. This is because there's severe tissue dehydration. Okay, now the technique, the way you pinch the skin, you need to pinch the skin on the abdomen, halfway between the umbilicus and side. Use your thumb and forefinger, not the fingertips. Then pinch forward, up and down. Release, then observe time to return. Okay, let us now discuss how to manage the classifications of dehydration that we've just discussed. Alright, so let's look at the management for no or mild dehydration. So for this, usually management is done at home. We use what we call as plan A to manage this. So there are 3 rules to plan A. That is, give more fluids. Okay, you give ORS, you give home solutions such as soup, rice water, and so on. Now, for those babies who are less than 6 months, you only give ORS. The second rule is you need to continue feeding. So breastfeeding should be done frequently, or the usual formula. Then for those babies more than 6 months, you can give vegetables, meat, fish for energy. Then you can also offer fruits like banana for potassium. So serve freshly prepared food 5 to 6 times per day. The third rule, which is the last rule, is you need to return to the clinic if worsening. So how do you know that the condition is worsening? If you notice many watery stools, poor intake, repeated vomiting, fever, and blood in stool, make sure that you return to the clinic. Okay, let's now look at the next management. Okay, so to manage some dehydration, we use what we call as plan B. So in this plan B, the main concentration is just fluid management, and that fluid is ORS. Now remember, we did mention that for us to classify a child as having some dehydration, meaning we need to have signs of listlessness, irritability, sunken eyes, the child is usually thirsty, and there is skin tag. Now we did mention that if you find any two of those signs that I've mentioned, that means the child has some dehydration. So plan B is all about fluid management, and that fluid is ORS that we are given. Now when it comes to the volumes, you need to look at the weight of the child and of course the age. Now this ORS is given in the first 4 hours. So if the child is less than 4 months and less than 5 kg, you are going to give 200 to 400 mils of ORS in the first 4 hours. Then if the child is 4 to 11 months and the weight is between 5 to 7.9 kgs, you are going to give 400 to 600 mils of ORS in the first 4 hours. If 12 months to 23 months and the weight is 8 to 10 kg, you give 600 to 800 mils of ORS in the first 4 hours. If that child is 2 years to 4 years and the weight is between 11 kg to 15 kg, you give 800 to 1200 mils of ORS in the first 4 hours. If 5 years to 14 years and the weight is 16 to 29 kg, you give 1200 mils to 2200 mils of ORS in the first 4 hours. And lastly, if above 15 years and more than 30 kg, you give 2200 to 4000 mils of ORS in the first 4 hours. Now, you also need to encourage the mother to continue breastfeeding. Then after you've given all these ORS in those first 4 hours, you need to do a reassessment and then adjust the fluids. Now, if at all there is severe signs that develop, you need to use plan C. Now, let's look at plan C. Alright, so for severe dehydration, we use plan C. So we did mention that for us to classify a child as having severe dehydration, it means the child has to have any two of the following signs, which is lethargic, unconsciousness, very sunken eyes, unable to drink, and also the skin tag. Okay, now management for the severe dehydration, we use IV fluids, and specifically the fluid of choice that we use is Ringer's lactate. Okay, now how do you give this Ringer's lactate? So in infants, those who are less than 1 year, you're going to give 30 mils of Ringer's lactate per kg in 1 hour. Then you're going to give 70 mils of Ringer's lactate per kg in 5 hours. Okay, and then those children between 1 year to 5 years, you're going to give 30 mils per kg of Ringer's lactate in 30 minutes. Then 70 mils of Ringer's lactate per kg in 2 hours 30 minutes. Okay, then you're going to reassess every 1 to 2 hours and then repeat if the pulse is weak. Then give ORS by mouth when the child can drink. So that is, you're going to give that ORS by mouth, that is 5 mils per kg per hour. Now, if at all the IV fluids are not available, you can use a nasogastric tube to give ORS. Now you're going to give 20 mils per kg per hour for 6 hours. Then reassess. Okay. Now, supposing this child, there is persistent vomiting or abdominal distension, you're going to give these fluids slowly. Okay. If there's persistent diarrhea for more than 14 days, refer that child for hospital care. If at all there is dysentery, meaning there is blood in stool, you can give ciprofloxacin 3 days. Okay, that is for 3 days. Then treat dehydration, give zinc, and then follow up in 2 days. All right. So that is plan C. Okay, so having looked at those management under plan C, I did mention that if the child has persistent diarrhea, that is for more than 14 days, you need to refer that child for hospital care. However, before you refer, you need to make sure that in that persistent diarrhea, make sure that first of all dehydration is present. If there is dehydration, treat the dehydration and then refer the child. However, if at all the diarrhea is persistent, like for more than 14 days, but there is no dehydration, just give multivitamins and minerals, including zinc, for 14 days. Then follow up in 5 days. So if there is no dehydration, do not refer the child. However, you can give multivitamins, zinc for 14 days, and then make a follow-up in 5 days. Okay, so this is a summary table that I've made for you, so you can go through it. It contains the classifications and the management, so you can pause the video and then study the table of what we've just discussed. Okay, I have a quiz for you. Question 1 says a 10-month-old baby has watery stools 6 times per day. The child is irritable, thirsty, and skin pinch is slow. Which plan are you going to use on this child? So if you said plan B, you are correct, because this child has some dehydration. So the management, of course, involves ORS and the reassessing. Question 2. A 2-year-old child is lethargic, cannot drink, has sunken eyes, skin pinch is very slow. How are you going to manage this child? Okay, so if you said you're going to manage this child using plan C, you're very correct, because this child has severe dehydration, okay, according to our classification. So when it comes to management, you're going to give IV fluids, which is Ringer's lactate, and then you're also going to give ORS. Question 3. A child has diarrhea for more than 14 days, but there's no dehydration. What are you going to do? Okay, so if you said you're going to give multivitamins and minerals, including zinc, for 14 days, you're correct. So not only that, you can also advise on feeding and then follow up in 5 days. Okay, now the last question. A child has blood in stool and some dehydration. How are you going to manage this child? Okay, if you said you are going to use plan B. You're correct, because you need to treat the dehydration. And if you also said you're going to give ciprofloxacin for 3 days, you're correct. Okay, so not only ciprofloxacin, you can also give zinc and then follow up in 2 days. Okay, that brings us to the end of our session today. You now know the definitions, the causes, the clinical features, the step-by-step management for plan A, B, and C. You know how to treat persistent diarrhea and dysentery. You also know how to assess severity and also how to respond. So drop a comment if you've ever managed a severe diarrhea case. I would love to hear your experience. If you found this video helpful, don't forget to like, subscribe, and hit that notification bell so you never miss clinical tutorials like this. Thanks for watching and stay healthy.